All right, guys, I believe we are live. Awesome, we're live, guys. Um, Guys, we're just gonna wait around a few minutes just to get started. We got a great show for you today. We got doctors of kidney tech. You get to get an insight into the innovation that's going on in kidney care. We're just waiting a few seconds just to see some more people get on. But at this time, if you're in the audience, please like and share just to get the algorithm going. And do me a favor in that comment section, mention who you are, where you're from, and why you're in kidney care. All right. Let's see here. Cool. All right. It looks like, okay, we got some people on. I'm going to go ahead and get started. Okay. All right. We're going to go ahead and get started. All right. What's up, San Antonio and world? I'm Dr. Qasim Butt, and I'm a kidney doctor, and I'm here to break down health in a simple way. And welcome to the 5th installment, round 5 of my webinar series entitled Disrupting Kidney Care, where we talk all things kidney and what's going on in the kidney care market. We've touched topics such as value-based care. We had some heavy hitters from the value-based care industry come on and talk. We also talked about home dialysis with different chief medical officers and different people. We also had one entitled The Patient Experience. Going over the patient experience, we actually had 3 patient advocates who were really outspoken, talk about their experience at kidney care and the downfalls and the pitfalls of it. And this one is entitled Doctors of Kidney Tech. And last I counted, I'm thinking we have around 490 attendees to this event. So that's super awesome. Again, and if you guys are out there, please like and share. And in that comment section right now, let me know who you are, why you're watching, and what you do, what's your relationship to kidney care. All right. And for those of you that are involved, that are watching, that are physicians, guess what? You can actually get CME credits for this. That's right. You can actually get educational credits. Just go to my website, yourkidneysyourhealth.com, yourkidneysyourhealth.com. Click on the Earn CME, and you can get a credit for CME completely for free. Okay. Now, so I gathered some of the brightest doctors out there, physicians that are involved in kidney innovation that I've got to meet over the last few years. Okay. They're here to talk about their journeys into medical device and technology, and go over the technology and devices they're actually coming up with to improve the lives of people with kidney care. So you're probably thinking, why should I invest in kidney tech or kidney innovation at this time? Well, because the headwinds are actually in its favor. Okay. Over the last few years, what I've noticed, probably over the last 2 to 3 years, companies coming into kidney care have raised tens to hundreds of millions of dollars to help innovate in the space. Okay. And why is this? Why is the innovation there? Well, I break it down to 3 reasons. Okay. One is the tremendous cost and inefficiencies in the kidney care market. That's no longer sustainable. So Medicare has to wake up and change it. Number 2, the Trump executive order on kidney health that was signed into law in 2019, the Advancing American Kidney Health Act, changed the game and really put the gas pedal on innovation. And number 3, this is 3. Number 3, I would say the introduction of value-based care into kidney care, which completely changes the incentive models, how doctors get paid, how health systems get paid, and everything that really is driving a lot of the cost savings and the different metrics that technology is really well suited to figure out. Okay. Now, let's get into our guests. I'm going straight into our guests. Now, the first one up to bat is a guy I know pretty well. We kind of have a relationship, not that kind of relationship. Now, when you hear the term chief medical officer, okay, and when you're a practicing physician in private practice, you often wonder, what does that take? You know, what is involved? What does it take to become one? After my first Zoom meeting with this guy, I was like, now I know what it takes. He so impressed me the first time I met him. He's a vascular surgeon. On his CV, he's got a little bit of Harvard. He's got a little bit of Dartmouth. He threw in some Department of Defense and U.S. Navy just for that God Bless America action too. Please welcome the Chief Medical Officer of Alio, Dr. David Whittaker. Dr. Whittaker, how you doing?
Hey, Qasim, how are you? Thanks for having me.
I'll call you Dave from here on out. So
please do.
Yeah.
Absolutely.
Let us know about yourself, man. Let us know about yourself.
Yeah, absolutely. Again, thanks so much for having us, getting us all together. This is a great conversation. I'm different, I guess is the best way to say. Just ask my wife; she'll admit that I'm definitely on the different side. So I kind of came around medicine a little bit circuitously. I started off at the Naval Academy, where I picked up my degree in mechanical engineering. Thought I was going to be an engineer at first, and I spent about a year with the Navy, and then I went off to med school. From there, I went to general surgery training. Deployed at the start of the Iraq War. Actually, realized I wanted a little more training in blood. So I went up to Dartmouth, got a fellowship up in vascular surgery up at Dartmouth, and then kind of made my way back down through the Navy and grew through the clinical ranks and the professional and military ranks. I was eventually the chief of vascular surgery at Walter Reed. And then I also shifted over to the Bureau of Medicine and Surgery as I grew up became captain and I led the Futures and Innovations group for the Navy Surgeon General. And then I was shifted over to the Defense Health Agency, where I ended up running their innovation group as their chief medical officer. And it was actually there that I met Alio. They were pitching a device early on, which was actually an implantable form. And I was smitten at the moment. When I grabbed a cup of coffee, I said, hey, this is really cool. So I retired after about 32 years of active duty service. And I was kind of deciding, did I want to go full-time into clinical practice or not? And there's a lot of opportunities out there. And the team at Alio said, hey, why don't you come join us as your chief medical officer? So I jumped on board, both feet in, and I've been having a great time ever since. So,
and you were surprised to me, David, and we can get into this later. Like, I love how, like, when people don't realize it's a med device, but DOD, Department of Defense, really has a hand in it with grants and other things. And they're really heavily involved for various reasons, national security reasons, whatever. But I was surprised when I first came into it, the interaction they have with the space as a whole. So
yeah, we could definitely come back around to that. But there's incredible opportunities there, both professionally as well as certainly from the funding perspective. And since cash is king in this, it's important.
All right, David, I got to bring up the next guest.
You got it. Absolutely.
Let's do it. Let's do it. Okay. Next up. Okay, I got this guy. Okay. You ever have a really meaningful conversation with someone where it kind of changes the perspective of how you think and how you approach things? Well, in May of 2021, I went to this conference called LSI, Life Science Intelligence. And the last day, the last day of a conference, right, where you're just kind of sitting there waiting for flights to take off. Well, this guy Nikhil was sitting there, and I knew he had a company. Sat next to him, and I think we talked for maybe an hour or two. We talked about family. We talked about his journey as a physician entrepreneur, gave me advice and even a book suggestion. I remember that. Shortly after that, I actually wound up resigning from my practice. Now, he was not the reason. There was confounding factors otherwise. But this guy went from being a full-time urologist to the co-founder of his own company. Not to mention, he has a laundry list of experience in surgical robotics and minimal invasive surgery. Please welcome the co-founder and CEO of Nephrodite, Dr. Nikhil Shah. Dr. Shah, Nikhil, how you doing, sir?
Hey, great, Kasim.
And you did not make me quit my job, okay? You did not do that.
So
but you do remember that conversation, right?
I absolutely do remember that conversation, and it was memorable for me as well. And in meeting you, I was captivated by your interest and your station where you were at that point, because I remember being in the exact same spot. I have to tell you though, it's a little humbling to follow David. Like I wish I would have actually gone last, because you're absolutely impressive, Dr. Whittaker. So I'm glad to be on the panel with you.
It's too much.
You guys are killing me. You guys are killing me.
Well, I started my career after leaving medical school, wanting to do surgery. I had high hopes of doing pediatric cardiac surgery, so I started a general surgery residency. And after several years, I left that and went to the National Institutes of Health as an NIH NIDDK scholar. And it was there that I sort of had a wake-up call. I spent 2 years in the lab and managed to get my master's in health management and health policy. And I really started to see things differently. At that point, I transitioned into urology, did several fellowships in urologic oncology and minimally invasive surgery. Our group in Detroit at the time, and the University of Michigan, was really pioneering robotic surgery at its inception, and so really took a liking to that. Started off early with a lot of exposure to renal transplantation and did a lot of that, and then quickly started my career just by default, because of my experience in robotics, as really a robotic assisted surgeon doing a lot of those surgeries. I moved to Atlanta fairly quickly and joined the Georgia Institute of Technology as an adjunct associate professor at the time, and really just started exploring a lot of my interest. And the epiphany for me came when I was giving a talk initially at Georgia Tech, which then led to Jet Propulsion Laboratories of all places, and then at Google. At that time, there was a little known private entity called Google X, which is really not too dissimilar. It was based out of sort of DARPA, if you will, and David knows that well. And that led us to German aerospace. And it was at German aerospace where we really got some ideas about how to recreate and innovate in this space. And so that's my journey in a nutshell. And it's been incredibly enlightening and insightful. I have to tell you that I did leave clinical practice several years ago to run our startup full time, and I have zero regrets, and I love every minute of it, and I wouldn't change a thing.
That is awesome. And let me bring up the next guest, and then we can all talk. Is that cool? Let's see here. Who we got next? Okay. So this next guy on the panel, he really has no discernible skill sets whatsoever. I'm merely bringing him on for comic relief and plan to make fun of him for the next hour or so. Okay, all right. He's got some talent, like a master's in biomedical innovation. He worked at the Texas Medical Innovation Center in Houston, helping develop medical devices. A former flight surgeon with the Air Force, and a family medical physician. Please welcome the senior medical director at Thrive Labs, my good friend, Dr. Lance Black. Lance, how you doing, man?
That's the best introduction I've ever received.
I was trying to be flattering. I was just really going for the full flatter right there. So.
Wow. We must be really good friends, Qasim, because that was great.
I planned for you to give it back to me at some point during this. So I just preemptively went for it. So go for it, Lance. Tell us about yourself.
Thanks, Qasim, and thanks for having us. Really appreciate it. This is going to be a fascinating panel. I'm excited. I think kidney innovation in particular, has been underserved for the past few decades, and I'm glad we're bringing it to the surface. So thanks for this opportunity. I don't know where to start, but I guess I'll start with my undergraduate being in biomedical engineering. Always interested in math and science. Okay, I'll reveal a little bit of my nerd self. Back in 1991, when Terminator 2 came out, and I saw Arnold rip off his arm and have that android thing, that was like, that's what I want to do with my life. I want to build androids. I literally went into college with that in my mindset. And thankfully, I was exposed to alternative careers, one of which was biomedical engineering. And I knew I wanted to combine engineering and medicine. I just didn't know how to do it. So I went to medical school with the intent of, I'll figure this out later on. I really didn't know what my career was going to be. And so I was sort of just putting one foot in front of the other, got through medicine with the backing of the U.S. Air Force, which is sort of my military entree. They helped me to pay for medical school and helped me to go through residency. They needed family medicine physicians at the time. So that's actually why I chose that career path, which was kind of nice in the fact that I didn't have to think about it. But anyway, it helped me because I became a generalist, and I've been able to carry that trait throughout my entire career. I know a little bit about a lot of things. I'm not a deep expert in any one thing, and
I find that really fascinating as well too. I know we got two surgeons on here, but when you understand medicine or internal medicine or family medicine, it kind of puts you in the realm of chronic care management and chronic disease, which is kind of cool, right? So you understand that, but that's cool. Now, so we got everyone on the panel. I'm so happy to be here. Now, this one is going to be running a little bit different than the previous ones. What we're going to do is something I call the 60-second pitch. Now, for those of you guys out there who's not familiar with the medtech space or startups as a whole, you may know the show Shark Tank, right? So essentially, we're going to be doing a mini version of Shark Tank, where each one of these panelists will actually have 60 seconds to go over their slide deck, tell us about what devices they're working on. And so the audience here, because a lot of y'all haven't seen innovation, what innovation in kidney care actually looks like, okay? Now, just so you know, there will be a winner at the end. That winner will get an investment from me of $5.
Yes.
Y'all didn't think I could bring the Lincolns like that, right? Now, that stock will be issued in preferred, not common, and I will get a board seat on your company as well. Now, while each presenter is going out there, everyone in the audience, I want you to list your questions and your comments. What do you think of the device? What questions do you have for them? They're all at the phase of their careers and at the phase of their companies where they could really use your input and, like to know what you guys think of them. Okay. So we're going to start. Who are we starting with? I'm going to start with Dr. Whittaker. Oh, and I forgot to mention our relationship. We both work for Alio. You're the CMO and I am the nephrology medical director. So little biased, just a little biased. So I'm going to go ahead, bring up the slide deck for everyone to see. Okay. All right. You ready, Dr. Whittaker? Let me get a timer. Okay.
Oh, ouch.
Well,
You're supposed to give me an extra
try to
20
do the
seconds.
60 seconds because not everyone wants to see the whole thing. All right. You ready?
Ready.
You ready, sir? On your mark, get set, go.
Qasim, thank you. So what is your first major problem that you experience with vascular access in your patients who have a fistula or a graft? We're all familiar with it. It's 5 p.m. on a Friday and a phone call comes in from your patient saying, hey, I don't know if something's going on with my fistula. What do? You don't know whether they had adequate dialysis. You don't know what their potassium level is. You don't know whether they got enough fluid off. So you send them to the emergency room. Your patient's worried, you're worried. Come along, Alio. Alio has come up with the world's first wearable, continuously worn, adhesive, disposable device that provides 24-hour, 7-day-a-week coverage and collects 15 seconds of data every 3 hours while it's being worn. And in that 15 seconds of data, you get the patient's heart rate, you get their skin temperature, you get quantitative hemoglobin, quantitative hematocrit, you get a potassium indicator that tells you whether or not their potassium is normal, and you have the opportunity to actually listen to their fistula from anywhere in the world as long as you can access a website. So take that same scenario in the future. Your patient calls you, you say, don't worry. You sit down at your computer, you see their potassium levels fine, you listen to the breathing, and you say, hey, you're actually doing okay, and I'll see you in clinic on Monday. And the other exciting aspect is the research and development team is currently working to add some additional features to it. These are not available yet, but SpO2, maybe even blood pressure and fluid status. We look
Awesome.
forward to having you join us.
Little over 60 seconds there, Dave. So I'm going to have to take back some of your time. Real quick, commercialization phase. Where are you as far as your product? Is it available? Is it not available? Where you're at?
Yeah, obviously very appropriate. So we are currently FDA cleared in the US as of March for the first set of parameters that I explained to you. So not SpO2, not fluid status, not blood pressure, but everything else we're FDA cleared for in patients with a functioning AV fistula.
And I'd like to mention the first device ever to non-invasively measure potassium, correct?
Yeah, absolutely. It's really a testimony to the team.
Next up, we got Dr. Nikhil Shah. You ready, sir?
Absolutely.
Go for it, Nikhil.
Yeah, I think pertinent to David and his talk, we are going to find that innovations in the space are going to be synergistic and collaborative. We looked at the current state of dialysis. There's been little or positive innovation in the space over the last 40 or 50 years since the inception of dialysis. And we looked at what patients were asking for. They were asking for changes to their access, not having arm access anymore. They didn't like the intermittency of treatment. They were looking for a continuous solution. And they didn't want to be strapped to a chair, whether it was at home or it was in a dialysis center. They were looking for mobility, portability, and a more continuous solution. So we've developed an implantable device that's a hybrid implantable and a wearable device that would allow patients to really experience the freedom from the chair. And at this point, we feel like this really meets the needs of patients. We need to have innovation in the space, and we've been working hard at that. I'll stop there.
Awesome. And where are you, Nikhil, as far as commercialization at this point?
Absolutely. So we are probably the most the youngest on this panel in terms of our device. We are certainly preclinical. We are building our minimal viable product, our human grade device at this point. Our hope is to be first in human in the next 18 to 24 months. Awesome.
And is it a peripheral device as well that it connects to, or is it?
Yeah. So there'll be an implantable filtration component, and then there'll be a wearable backpack that will allow for the exchange of water.
Awesome. Giving people that mobility to do dialysis throughout their day in a slow, gentle way, essentially, right?
That's exactly right.
Awesome. Okay. Next up, we got Dr. Lance Black. Go for it, man. Oh,
Thanks,
let me hold on a second. I got to put your slide up, right?
I worked hard on that slide.
Yeah. All right, man. Go for it.
Thanks. As I was mentioning earlier, I think the kidney has been largely forgotten. I think we really don't worry about the kidney until it's crashing, until we need dialysis or considerations for dialysis. We are used to augmenting heart function, lung function under times of acute stress or surgery. In fact, we breathe for the patients, right? Or we pace the heart if something goes wrong. But the kidney, what do we do to augment its function, particularly under times of acute stress? That's where Thrive Lab steps in. We've developed the world's first renal assist device. It's a catheter-based system, so it goes through the urethra to the ureters to the kidney, and it modifies the intrarenal pressures to really counteract any disruption in the pressure gradient that is so vital to kidney function. So as much as the heart needs a very specific voltage in order to conduct and to beat, the kidney needs a very specific pressure gradient that's easily disrupted. Right now, we're focusing on supporting patients who have renal insufficiency or undergoing severe or complex surgery, like cardiothoracic surgery, and requiring cardiopulmonary bypass or a pump. The kidneys don't like that pump, and they typically have some sort of injury following that surgery. So we're looking to prevent that and ultimately prevent people from having to go on dialysis or need renal assist or renal replacement therapy.
That's awesome. And as far as commercialization, man, where are you guys at? Is it available?
No, it's pre-commercial. We're actually going through feasibility studies right now and looking forward to doing our pivotal study sometime next year.
You know, Lance, like in the industry as a whole, the whole notion is to go upstream now. You see what I'm saying? It's not to concentrate on dialysis. It's not to concentrate on CKD 4 or 5. It's to go up to 3, 2, 1, you know, up higher to 100%. Slow that progression. But your company is actually talking about acute kidney injury and preventing it, right? And even preventing the progression, that late stage kidney disease patient that you don't want to put on dialysis, but it can kind of help with that diuresis or getting that fluid volume off, whatever it is, right?
And not to mention the complications that result indirectly from renal function dysfunction. If your kidney's not working, your heart's not working right, the volume's not being managed, you have other organ failure. So we're looking to reduce complications overall.
Kidney patients are sick patients, so anything you can do to prevent or preserve kidney function is so crucial. Okay.
100%.
Awesome, man. Awesome, guys. Well, audience, you guys put your questions in the questions or comments about their devices or about their companies in there, and I'm sure they'll be happy to answer it. Okay. Now we're going to go into the Q&A set. We're going to go into question section where we're just going to ask the doctors their experiences and go from there. Afterwards, at the end, we will leave about 10-15 minutes for questions for our docs, and you guys feel free to message and everything. Okay. So, guys, first, right off the bat, what brought you into medtech? I know we kind of elaborated into it, but what really brought you into it as opposed to clinical practice?
I'll start us off, if that's
okay.
Go
for it, man. Go for it. I know you're the Terminator, right? So literally,
it's all about the
Terminator is the reason you're in, right? So go for it.
No, just sitting in clinic and trying to churn through 25, 35 patients per day, recognizing how the technology itself was disabling for me to actually do the work that I was trying to do. And recognizing that, you know, as much as I wanted to go into figuring out why, I really couldn't do that. I was too busy taking care of patients. And so it made me start to think through, is there a career path where I can start to engineer solutions, whether it be on the software side, because we all hate EMRs, or whether it be on the tech side, the device side, because we have a lot of technology out there that was created back in the 70s and 80s and hasn't been updated since. Yeah. And so that's what got me really excited about going into the medtech space. And so that's the point where I started to look elsewhere outside of clinical practice. And it was my separation from the military that sort of forced me from a career perspective to consider alternative careers. And it's a long story how I got to where I am today. But ultimately, I went back to school, studied product development and industrial design at Georgia Tech. And that was really a turning point. It made me recognize that there's a lot of great entrepreneurs in the space running startups, trying to figure stuff out from the bare bones. And that's what got me excited and continue to work with those folks today.
You know, I share that same frustration. You know, like I feel like your personal life moves so forward with all this technology, but medicine is so far behind.
Right.
And particularly EMRs, like you got people in the audience who ever worked with EMRs, like some of them are so backwards and so antiquated. You're like, why am I using this? You know, like it's kind of so frustrating. And even like you said, the day-to-day of like, you know, seeing patients and you just feel like you're treading water, right? You're not really being impactful.
Exactly.
Right? Nikhil, go for it, man. Oh, Nikhil, go for it.
No, I'm happy to go next. You know, for me, urology has been and is a field that urologists love to tinker with toys. We have endoscopy and endourology, where we're always, you know, doing cystoscopies and procedural based things. And so we're sort of a band of or a group of people that loves to use devices and technology. And moving on from there, it was the robotics world that really fascinated me. I mean, just seeing the advent of robot, hearing the history of Stanford Research Labs and Dr. Fred Mall, and how he came to sort of really bring about a surgical robotic device was captivating to me. And so as I expanded my education and my career, and I began speaking more about the surgeries in the field, I really started to just get involved and started to meet like-minded people. And I think that was critical. And I think that the point here is and similar to Lance, and I'm sure with David's experience, is that once you sort of bite the apple, right? Once you start meeting people that are like-minded and ask questions and have that similar intellectual curiosity, it's hard to ignore it. And at that point, I knew I was probably going on a ride that was going to take me to many different places.
Dave, go for it, man.
Yeah, absolutely. No, I mean, very similar. Humans are good at human things, like caring for people, talking to people. And my wife always says that I probably made a mistake going into vascular surgery because I'm actually a nice guy. And
that is true. That is so true. It just clicked in my head. You're really nice for a vascular surgeon. I usually get yelled at when I call
I
one.
like my patients. My patients. I've made house calls. And what struck me was that we had this inability to scale medicine, and trying to figure out how to get the machines to do the things that were just repeatable for the humans and allow the humans to do what we're good at has always been a fascination for me. And then also the military really has a big focus on how do you take care of people in austere and remote environments, from middle of the Atlantic Ocean to the middle of a desert somewhere to someday maybe up in space. So how do you do the things that the machines can do and let them run? And then that kind of brings you back into the role to sort of think, provide. And one of my favorite books, my wife gave it to me, is Cutting for Stone. If anybody wants a great book, Cutting for Stone. And there's if you've read it, one of my favorite things is, at time of crisis, what therapy is administered via the ears, and it's words of comfort. And I know that might sound a little bit cheesy, but it's been such a great thing. And that's what we're good at as doctors. And so I really look at medicine as how can we scale it? How can we get it more out? And so for me, Alio was it was a no-brainer. It's like, how can we scale monitoring all these patients' fistulas and allow us to focus on the people that really need care at that time?
The one thing I was taken aback by, first off, just in the conversation, we're talking about kidney care and nephrology, and I'm the only nephrologist. You see what I'm saying? And it's weird that non-nephrologists are actually innovating kidney care, but also just the sheer fact that most of the innovators in kidney care or healthcare as a whole, I've seen are engineers, right? Like they're the ones that have the minds that kind of implement a lot of this change or come up with the ideas. And why do you guys think that is? Like, have you guys noticed that too?
I think engineering, I always tell people engineering ruined me as a physician because it provides a certain mindset where you're looking at the world as a series of problems and you're constantly on the hunt for the solution and figuring out whether it's stupid stuff like I want something to prop up my cell phone so I can lay down and watch movies, all the way to serious, more complex issues. You see the world as a series of problems. When you're in medicine, you're trained to put into practice things that have already come before you and do so effectively so that it's best for the patient. And you're not really paid to be creative in medicine, although there are cases, I will admit, that you have to be creative, but you're really paid to apply the standard of care, right? And, if you want to do research, that's great. That's sort of a subsequent to your career. It's not the same mindset, though. It makes it challenging. So I felt like in clinical practice, I was frustrated the whole time because I saw problems that I really didn't have the time or their energy, much less to focus on and try to figure them out.
I think that's right. Qasim, I think probably similar. I hate that I'm sort of speaking for you too, David, but we're technicians, and as technicians, similar to what Lance just brought up, we fix problems, and we have to fix them well, right? There's the patients are on the table, and you've got to take care of them. And we have that sort of technical skill and curiosity, but I think the issue there as well is when you become a physician in years of medical school and training, you really have a tunnel vision and single focus that hasn't really allowed you to think outside the box or outside your comfort area, and you don't really have the time to do that. And that may be a segue into some of the questions that you have later, but you can't really dabble in medicine and then dabble in research or dabble in innovation. it's really tough. And then you end up becoming mediocre at everything. And so finding that balance and then making a choice is really ultimately where you're headed when you start going down that path.
Yeah, I'd like to just pull the thread on that a little bit, because I agree completely. And I think one of the challenges is that by the time you get done with your training, you're out there, you're in practice. The next thing you know, your clinic has gone from 4 to 14 to 40. You've got a book schedule, right? So then the next thing you know, you've got these hours that are just laying upon hours. And all the things that you learned in your undergrad that you might be able to apply to some of the innovations start to slowly slip away. So I think there might be a tendency more on the engineering side that just because so much was crammed down your head up front, that some of it hangs around a little bit longer. But I think it's a really important thing for people to recognize is that in general, you start off in clinical practice, you got to get a good sense of what's going on out there. And then you kind of circle back around and then you can kind of come at it from an engineering approach, but you don't have to be an engineer, right? A lot of this stuff is pretty simple. It's just like,
I think it may stem from the fact of the principle of non-malfeasance, do no harm. You know what I'm saying? It kind of inhibits us, whereas engineers go fast and break things. You know what I'm saying? So it's like a different logic, and we can't do that, right? Like we can't just implement everything just because and just see how we can't break things, right? Like it's called a lawsuit, right? Or a death, like that's even worse. Okay, but how was that transition out? For me, it's been like a partial out, right? I'm still practicing part-time medicine. But how was your transition out when you left medicine? Was it abrupt? I think, Lance, you went up pretty abruptly. But it seems like a lot of you like kind of dabbled here and there back and forth. Is that right or no?
Yeah, maybe I'll jump on that one first because I'm not out yet.
Yeah.
And it's so I've been fortunate that the Department of Defense, and having recently retired, that so I work with our local community hospital, and they've been kind enough to let me continue to practice, but not in the same regimented way that I had to for all the years before. So I'm actually working as a Red Cross volunteer. It's incredibly rewarding. I love the fact that I have more time to spend. Again, going back to I probably should have been a primary care doc. I get to actually spend time going over the AAA and the fact that claudication is sometimes best managed with walking regimens and things like that, right? So I'm not completely out. And to be honest, I don't know if I ever will be. I actually really enjoy the practice of medicine. It's just a matter of trying to figure out a way to fit in.
I think that balance is hard, right? To figure out like how much you can practice and can't. And Nikhil, you left completely, right, man?
I did. So I embarked on it's sort of at least in surgery where I was and how I trained is as you sort of go up in the years and get more experience, you also become the one that they lean on for leadership roles. You serve on an enormous number of committees at the hospital, which tend to be all volunteer. And as you get pulled, you continue to take on more. And so I started taking on a 80, 20, 70, 30, 60, 40, so on and so forth, where I was splitting admin with a little bit of research at Georgia Tech and other places with my clinical practice. And at one point, it just became clear as we started to make milestones and accolades in certain things. I really had a decision to make. I couldn't. What did it for me was when I was waking up every day. I loved the practice of medicine. I loved taking care of my patients, but I would wake up every morning and think about the device and all the things that I had to do, and I'd go to bed thinking about the device and all the things I had to do. And I sort of looked at my family and my spouse and I said, yeah, is this a sign? And my wife said, oh, we're way beyond signs at this point. So you just have to realize what's staring at you in the face and make the decision. And it made sense for where we were at the need of the company as well.
But I realize is something's got to give. You know what I'm saying? At a certain point, especially when you're juggling so many things. Like for me, like I'm nephrology, but I'm also interventional nephrology. And I really haven't practiced interventional nephrology in the last, I practice it a little bit, but I'm probably going to have to give it up to some degree. And I'm like you guys, Dave and Nikhil, like I love working with my hands, but I just can't. In the schedule I have now, you have to give it up. It's just too
I think, Cass, also as technicians, you have to do in order to maintain that true quality of skill. And you probably could still do it, but as the years go on and you're not doing it the number of times, I had to sit back and say, am I really offering the best for my patients if I'm not at my, my optimal? And so I made the decision, but I made it less for that and more for I was ready to make a change.
See, I should have done what you guys have done and made a slow change.
You left, right? Like at one time?
Yeah, don't follow in my footsteps, whoever's out there listening. I made a clean break.
Wow.
I think that what I
You kind of ghosted medicine? Is that what you're saying?
What's that?
You ghosted medicine?
I did. It felt, yeah. I mean, there is a good relationship analogy there. It felt like a divorce. Like Nikhil was talking about how much time and effort he put into it, obviously med school, residency, beyond. And there's this huge sunk cost fallacy. It's like, man, I put that much time in it. I'm doing this for the rest of my life. So that was really hard to sort of let go. And you have that emotional attachment to the time, effort that you spent. And then that leads to irrational decision making. I mean, it's very much like sunk cost fallacy. I was fortunate enough to have to really make a decision anyway, because I was getting out of the military. I finished my commitment. I was looking at other clinical practices, and I was like, man, I unlike Dave and Nikhil, I felt like I was in the wrong place. Like I did enjoy some aspects of medicine, but I knew it wasn't cut out for me. I didn't want to do this for the next 25 years.
How long did you practice, man?
Including residency, 7 total. Like I probably wouldn't have practiced a year out of residency had it not been for the military making me, which I'm actually pretty thankful for.
Yeah.
I'm pretty thankful for that because I got some experience there. But no, I felt like I was in the wrong spot, and it was really awkward. I felt like I was in the wrong spot. I had put all this time and effort into it. I had conversations with my wife. I'm like, what am I doing? She fortunately was going back to work as I was coming out of the military. So I had a chance to take a step back, and I went into it. I call it a transitional program. It was a master's program at Georgia Tech. And it was like, how do you start a device company in the med space? That's kind of what it was about. And so that really helped me make the transition, understand where I could plug my skills in as a physician and as an engineer. And the startup space really caught my eye because that was where a lot of them, I felt like the innovation was actually happening.
Yeah.
So if it wasn't for that program, I probably would have been treading water for some time, but I'm thankful for that.
I think that's where a lot of physicians are when they don't know what they want to do or they're frustrated with medicine. It's like you're treading water and trying to figure it out.
Yeah.
But can I ask? Go ahead, Dave. Go for it.
Say, Qasim, one of the other challenges, at least from the CMO role, is it depends a little bit who you're talking to about what the clinical relevance matters. And I realized there may be some investors listening. There's probably a lot of docs out there. But so if you're talking to an investor as a CMO, they want to know that you're 122% focused on the company, right? Like you shouldn't be distracted with your clinical practice at all. But when you're out there talking to the docs, they want to know that you can still relate, that you still have a good sense. So they want to know that you're.
And I've noticed when I talk to some docs that are out for a while, their language changes, right? They talk different. They talk like business guys. You know what I'm saying? So it's doesn't connect in the same way. And I've noticed that because I've talked to guys that were older than me when I first started looking into stuff. Like I remember a guy 55, 60 years old. And I was like, you don't talk like me. Like you use different acronyms.
Nobody talks like you, Qasim.
Well, you have to use a lower level vocabulary, Dave.
Dumb it down, Dave.
See, I knew, Lance. I knew you were coming at me. I knew you were going to come at me, Lance. Okay, so real quick, is industry as fulfilling as clinical medicine? Yeah, it's like a quick spiel on each one, or is it in a different way? Or
I don't think they're not comparable. I don't think they're comparable, Qasim. I think it's the question is what was I looking for? At that point in my career, I was happy with the clinical care that I had given. I was ready to transition, whether I realized it at the point that I was ready. I was looking for something different and something invigorating and adventurous and stimulating. And so it brought to me the same passion and vigor that I had when I started medicine. That did not really pause. I always thoroughly enjoyed medicine.
It's like a different angle. You're seeing medicine at a different angle. Yeah.
But I was enjoying something differently. And the impact, the way I sort of justify it, I guess, is the impact I was making for each individual patient was priceless. But now I have the ability, to work on something that could impact many, many more. And that really gives me pause as well.
And I think that what's interesting is the point of care is such a it's a difficult place to have like huge systematic change, right? You can't do it at the point of care as a clinician. It's nice to be a part of a company or an organization or like a system that can actually impact so many more lives. So Dave or Lance, go for it.
I define fulfilling as like, I'm trying not to use like cheesy words like it's my calling, but I'm not looking forward to retirement, right? I don't feel like it's a job. I look forward to going to work every day. I don't like separate my work life from my personal life. I'm actually pretty blended, which some people don't like, and I understand. But that's kind of how I define fulfilling. And I didn't have that mindset when I was in medicine. I was looking at my watch. In fact, one of the things that woke me up to it was there was a patient that I saw, and you guys can all relate. You're seeing them. I think it was a general abdominal exam or whatever, and I'm taking a look at her, and I'm like, okay, I think it's this, this, and this. And as I have my hand on the doorknob, she's like, "Oh yeah, doc, there's one more thing." And you're like, "Oh crap, I just going to be late for my next patient." I sat down and she's like, "I think I'm depressed." And she started crying. And instead of being like sympathetic and advocating and be like, "Hey, that's okay. That's what I'm here for. I'm here to help you through this." I looked at my watch. That was the first thing I did. And I was like, "Oh shit, that's going to be another 45 minutes. And my drive home from clinic that day, it really dawned on me. It's like, I think I'm in the wrong place, because to me, being fulfilled is like just where I'm at my best, right? And that definitely was not where I was at my best if I'm looking at my watch when somebody's complaining of depression.
And can I tell you this, man? Like, so now that I practice part-time, like there's a difference between practicing medicine and being overwhelmed with medicine. And so when you actually just practice it just in part-time bursts, you can actually appreciate it more in a weird way. And I totally feel what you're saying. Dave, what the fulfilling part, go for it. And then I'm going to ask you questions about your companies. Go for it.
Yeah, I think Lance hit that one on the head for me. I think, and Nikhil, I agree. They're not the same, but for me, I've got to have them both. I think one without the other is not going to work. I thrive in both, so I get the enthusiasm to go for the, how can we do this better approach from the innovation side by seeing the patients, and then equally so, I'm thrilled to see the patients and then try and figure out, how else can we do it. So the two of them to me they're kind of inseparable, and I hope they'll always stay that way.
Cool. All right, let's get into your companies, because I really want to talk about your companies. What are your companies doing to disrupt kidney care? Like, what are you guys doing that's so different that it's going to disrupt it? Go for it. Anybody?
Yeah, I'll jump in. So we were looking at patients. If you took a patient without kidney disease and one with kidney disease, when they face different aspects of care within their life cycle, whether it's a surgery or a pneumonia, the outcomes are different. And it's not just the outcomes as it relates to the kidney, it's outcomes as in the complications from the surgery, or the fact that they got sepsis, or mortality rates are higher, morbidity rates are higher. And so we were trying to figure out, how do we take the patient who has pre-existing renal insufficiency and bring up their renal function so that they operate like a patient who doesn't have renal insufficiency. And so that's where the concept of how do we augment, like we thought of ventricular assist devices, VADs. That's why we call it a RAD, a renal assist device. We thought about what is it doing that's supporting that organ. Well, in the case of VADs, it's actually forcing blood in the direction that the heart's going to pump anyway. So it takes pressure off the heart, right, to do its job. How do we take pressure off the kidney? The kidney operates on a very specific pressure gradient. So what we've done is we introduce a negative pressure in the kidney. It lowers the threshold for which the kidney can filter. So it makes it easier for the kidney to do its job. So during these times of acute stress, we're sort of like taking the weight off the kidney and saying, it's okay, we're going to take some of this pressure away from you, and so you can filter easier. And what we're seeing, we've already done this in heart failure patients, we're seeing that their renal function is improving actually while we're augmenting, and they actually have outcomes that are improved or equilateral to those patients who don't have renal insufficiency. So that's the idea behind our device and our concept. And obviously we're still studying it, and we have to study it in multiple applications, but we're really excited about the early results so far.
Well, even the diagnosis of AKI, or acute kidney injury in the hospital, leads to longer hospital stays. It leads to just overall bad results. I remember going over in the hospital system that was, part of like their.
Yeah, I think it's a canary in the coal mine. I think it's just showing you that the patient is not under homeostasis any longer, and everything just starts to kind of cascade from there. And so if we can maintain the homeostasis longer, or during the time of acute stress or even recovery, there's a likely chance of survival and other morbidities go away.
I can see your device, especially like in the CHF market, like when a person's coming in fluid overloaded, and that
Sure.
device is kind of helping getting that urine off, and not just urine off, excuse me, creating that negative pressure gradient to help the kidneys work a little bit better. Nikhil, go tell us about you. How are you disrupting kidney care, man?
I mean, I think what's fascinating is similar to Lance and they're looking at the VAD. We did the very same thing. We started to ask very basic questions, which was why is dialysis care intermittent? Why do patients only dialyze 3 times a week? The fact that they had to go to a center in a city like Atlanta and other U.S. cities, we see this dynamic all the time. The patient waits for the bus doesn't show up, the patient doesn't make it to dialysis, and then they get non-compliant patient who then isn't able to get to their dialysis appointment, ends up in the emergency room and then in the ICU. And so it was the intermittency of care. Why was it that in the time that we were at several years ago, that we had seen innovation in the cardiac space, in the robotic space, in the neuroscience space, but we had seen a positive innovation on the renal care side? And there's a lot of reasons for that. But we wanted to ask the question, then next, what would make a difference for patients? So we did exhaustive patient queries and interviews. And we came down to the fact that they really wanted a continuous solution that acted like the kidney, kind of a renal replacement solution. And what we did was we took what we thought was the best of peritoneal dialysis, the fact that but we didn't want to use the abdomen, and we took the best of hemodialysis, and we kind of put them together. And then we used the VAD, and we said, what does the VAD do? And we wanted to kind of be the VAD for kidney, but with membranes inside. So we're continuously filtering, and then we have a way to remove the water as well as the toxins in the middle metabolites.
Is your device really just like a stepping stone towards the artificial kidney? Is that what we're talking about, kind of?
Yeah, I think the VAD started, the ventricular assist device started as a bridge to transplant, and so what it was doing was keeping patients healthy enough to get their transplant. And we still have that issue, right, with kidneys. It takes 5 years to get a kidney in the United States. And unfortunately, the morbidity and mortality over 5 years of waiting for the kidney on intermittent dialysis
they don't qualify anymore. All of a sudden, they're not a candidate.
And so we see a role for not only just like the VAD that starts out as a bridge to transplant, we also see ourselves as a potential standalone device, because there are many patients that aren't transplant candidates. And so, yes, there could be a solution in xenotransplantation. There could be a solution in a true artificial kidney. But we think that a true renal replacement, a hemofiltration device that works continuously to really keep the urea levels down and the middle metabolites down and allow you to exchange water as well, we think that that's a great next step and one that would be robust for a long time.
And your logic makes sense, because that's why home dialysis has such better outcomes, because of the continuous or like more frequency of dialysis and less intermittency of it. And even the
That's
data
exactly right.
proves, like the weekend, the Monday, Wednesday, Friday, Saturday, Sundays, and Monday is the day you die.
Yep.
Mortality goes up. Because
what we're hearing from our home hemodialysis patients, though, is the self-cannulation. They've got to sit longer in a chair and be sort of tied down to a chair. They lack even more mobility doing that. And I that could improve, but we do think that the next step could be a one that's more portable and mobile.
Okay. Guys, do me a favor, put some questions or comments in the session if you have any for our guests. We're coming up on time. Dr. Whittaker, how are you disrupting kidney care, sir?
Yeah, thanks, Qasim. It's I think one of the questions is how do you scale great care, right? Like if we could take you and we could send you home with every single one of our patients and you just lived with them, and every 3 hours you sat there and you listened with your stethoscope and you drew some blood work off and you went ahead and did a good physical exam. I mean, that patient, well, they might think it's a little creepy, but besides that, that patient would get phenomenal care, right? So in current practice, most of these patients, and depending upon where they're getting their care for, they're getting maybe 1 to 2 blood draws per month. They're seen in the clinic when they come in for dialysis, but they're typically only seen by a nephrologist once or twice a month. And so the co-founders for the company, Dave Kargantla and Samit Gupta, made a decision that they were fortunate, right? They were actually, he was in medical school and he's like, hey, this is kind of crazy. Like, isn't there a better way to do this? So together they took this concept and they said, what if we can monitor a patient all the time? So instead of 2 to 3 data points per month, you've got 240 data points per month. And all that's being relayed back to care providers who can then sit there and look at that and say, this patient looks like they're heading for trouble. Let's get them into the clinic, not the emergency room, not a hospitalization before they're having difficulties. So the big change here is the ability to actually bring great care and scale it across a huge population to reduce hospitalizations, reduce ED visits, maybe even in the home hemo. It's kind of interesting because if you can actually measure this on a more continuous basis, start to really personalize the care that those patients are getting.
And also, what's cool about Leo too is like the sheer fact you're taking data that used to be intermittent and you're making it continuous in real time, right? Like, and so you're taking data and getting trends, right? And so as opposed to before, you waited a week or two or a month to see trends.
Exactly.
And now you can see it more often and make adjustments accordingly, which I think is super cool. So what trends in kidney, let me see. Oh, no. What are the biggest hurdles your device or company faces? You don't have to be very specific, but what do you think is some, I'm going to take it to Nikhil because, he's the founder, he's the CEO.
Sure. Well, ours is an incredibly complex device with having a surgically implantable device and a wearable. This is on the regulatory side, one of the most burdensome. It's a class 3 device, and so there'll be a tremendous regulatory path for us. But I do believe that, as you had mentioned, in 2019, in the summer of 2019, the mandate that was put by the Fed to really start paying more attention in the kidney care space, I think had an impact not only with CMS and Medicare, but also at the level of the FDA and regulatory. And I think as we continue to push forward, having a close interaction with the regulatory bodies will really be great. But I think with a class 3 device, the regulatory burden is significant.
Absolutely. Lance, go for it, man.
Yeah, I think I would share that more specifically around the regulatory burden. I didn't realize how complicated performing clinical trials are, particularly first in human or early feasibility study trials. I mean, it's a scary thing when you produce.
You're de novo, right? You're not 510.
De novo, yeah.
You're de novo, not 510.
De novo.
Right? Yeah.
Yeah, 510K with de novo. It can be similar to a PMA or a class 3 device. It's not usually as cumbersome as maybe what Nikhil is having to go through, but we do have to do early feasibility studies and then do a pivotal trial with several hundred patients, probably. But yeah, what I was getting at is it's super costly, very complex. You want to make sure you pick the right endpoints, pick the right study model. You want to make sure you're reflecting the positive benefits of your device at the same time doing good sound science. Being on this side of it, being on the business side of it was really eye-opening for me. And I always thought like innovation is you're at the bench top and you're like eureka moment and you invent some new device, but innovation is happening like every minute of every day in early stage companies because you're having to be creative in how you model your clinical trial, be creative in how you recruit patients or expedite patient recruitment, be creative in all of these aspects that I really didn't get exposure to until recently. And so with that level of creativity comes subjectivity, which then comes complexity. So I would say that clinical trials have been where I've been focused, but also one of the more complicated pieces and barriers to entry.
Cool. Dr. Dave, go for it, man. What's the biggest
I think for every company, particularly in the early stages, cash is king, right? Just having enough money to keep the payrolls going.
That's what I thought Nikhil was going to bring up. Yeah.
So that is always a big factor. Regulatory is always an issue. We've been fortunate. We've got an amazing team of regulatory consultants and employees and people that know this stuff inside and out. So we were able to get that first clearance through to the brilliance of that team. I think when I look at it from dialysis, it's interesting. The nephrology group, I would actually say it's data sharing, and it's some of the large dialysis organizations. You're trying to break into an area that has a lot of money associated with it, right? And there's a lot of pathways moving forward, and there's a lot of data. A lot of what we do is based upon the data science, and being able to get a hold of that data can be challenging. My understanding, I think, is the 21st Century Cures Act has tried to break open some pathways so that data can be shared amongst those entrepreneurs and innovators out there who want to do bigger things with that. But I think the data sharing is definitely a big access or a big aspect of it. The other part is the fact that a lot of what we're all working on is sort of cost avoidance. Like, hey, use our device and we will prevent the problem from happening. We'll prevent AKI. we're going to go ahead and we're going to prevent infections. In our case, we're going to prevent hospitalizations. So that cost avoidance model is sometimes hard to get through the purchasing committees of hospitals. So that's another challenge. It's not like you can come out and say, hey, use your device and your patient's going to feel great tomorrow. Well, that's not the case. You're actually looking down the future. So
and that's going to go into our other talk about value-based care as well too. But I find, you know, what's interesting is like to find out those early adopters, right, of a product in a market that's not used to innovation, right? And so that's always, and I feel like the nephrologists in particular are very over-analytical kind of people, so they're very apprehensive about specifically new devices, or or want the data, right, Lance? Like, like
you're gonna say doctors are the biggest barrier. Is that what you're gonna say?
I didn't say it. You did. Okay.
Okay.
All right. Let's see here. Okay. Like, what trends in kidney care and the trend towards value-based care, how is that going to be impacting the device, the device market as a whole, and even your company, that trend towards value-based care?
I'll jump on this one and just say, I think, so I like to believe that I painted a nice picture here of 240 data points a month being much better than 1 to 2 data points. And the idea here is that you've got trend lines, you're able to monitor your patients in remote settings. The US is moving towards a home hemodialysis agenda, which I think is fantastic from the lifestyles and perspective of the patients. So the ability, if we throw the Alio hat on here for a second, the ability for Alio to come in and provide comfort and confidence for these patients that are suffering from this chronic disease, and know that they're essentially always under the watch of a provider. The hope here is that not only does that provide comfort for them, so I come back to my, what can we provide but words of comfort. So that provides comfort for the patient, but hopefully also it identifies some of those early problematic patients, the ones that just want to have that extra piece of pie at Thanksgiving, right? The ones that maybe are going to skip a day of dialysis, and is it okay or not? So the idea here is to avoid hospitalizations, avoid emergency department visits, try and get to the fistula or graft that's clotted earlier rather than later, and then provide comfort for both the providers and the patients.
And to your point too, proving a savings is it's a hard sell sometimes. That's a really hard sell. It's like, I save you $500 a month or $200 a month or $3,000 a year. Like, that's a hard sell. But yeah, Lance, go for it, man.
Yeah, I think it used to be said, don't make a vitamin, make a painkiller, because vitamins obviously prevent disease down the road. Painkillers address a problem that's apparent, and people are more willing to pay for those painkillers. I think value-based care, that trend is sort of reversing that a little bit, and they're recognizing the value of prevention, or a prevention model, compared to that's more sick care, what people kind of call. I mean, we were looking at the numbers recently. Like 1% of the entire federal budget is spent on patients on dialysis. Another percent of the entire federal budget is spent on chronic kidney disease management. Those kind of numbers are unsustainable as the population continues to grow, and there's pressures on the government to reduce spending. So we're in the business of preventing worst case scenarios. And to Dave's point, it's a very difficult economical case to build. I mean, you have to do the studies to prove it so Medicare can reimburse you. You have to demonstrate what it is you're saying. You can't just say, we're going to reduce length of stay by 2 days. I had a hospital CEO told me, if I believed everything products told me, that patients wouldn't be spending any time in the hospital. They would have no length of stay. So you can't just say those things like you used to be able to maybe 10 years ago. Now you really have to prove them. And that's the big burden when it comes to trying to fit into the value-based care prevention model, is giving the evidence to suggest that, because those studies are usually a lot larger and more timely and more costly.
So Nikhil, just curious, so like with the value-based care, right? The big push with value-based care medicine, the kidney care models that CMS came out, is the home dialysis, right? Is home dialysis. Do you fit into that? Like, are those I mean, are you clearly fit into the general trend, but as far as billing and all that kind of stuff, is that where you guys will fit, or is you're going to go for a different kind of CPT code or something or different?
Yeah, no, so a couple of things to put what Lance just said in perspective. The United States government spends 2% of its federal budget on education, 2% of its budget on education, and yet 1 to 2% is on one disease state, which is end-stage kidney disease and dialysis, not heart disease or anything else. So it is really impactful. When you talk about our device, yeah, I mean, our device will have an implantable component. We think that there'll be similar codes to perhaps the LVAD model and or renal transplantation, we can certainly piggyback on those. But in terms of overall care, we believe that a continuous solution will keep patients healthier. It will prevent the ongoing morbidity associated with intermittency of dialysis and all the complications to the viscera and to the blood vessels. So we think a continuous solution that allows for exchange and removal of toxins will actually keep patients healthier and enjoy a quality of life. And I think that there's tons of synergy also with things that you guys are doing at Alio and even systems that Lance and others are working on. A remote patient monitoring device for someone that's now not needing to go to the hospital or a center could spare blood sticks and could allow a continuous form of information for patients like ours that are continuing to enjoy a better quality of life and actually be healthier. And so we think that this movement here in the kidney space, while it's small and there's not a lot of companies working in it right now, it's growing. And I think that it's going to end up being a large collaborative and synergistic effort. We're really excited about it.
Yeah, well, I mean, with your device too, Nikhil, like again, that continuous dialysis, the biggest cause for admission is these people are CHF, fluid overload admissions, right? So a continuous, nice, like continuous stream, like almost like a normal kidney would be really, really advantageous to prevent hospitalizations, just to prove it, right?
Yeah, what we tell people is we're not trying to be like a dialyzer, because that's trying to do a lot of work in a very short time. We're trying to offer a benefit over a 24/7 situation and a longer term of taking off urea and water over time. So you're exactly right.
Okay. So let me see here. We got some questions here. Let's see here. So actually, Dave, for you, your CEO just texted, how do we solve the incredibly siloed data sets in end-stage kidney disease care? How do we get that? How do we get access to that?
Yeah, so obviously he and I are thinking about things very similarly, right? In terms of the fact that data and this data sharing is, we can do so much with data, right? I code as a hobby, so it's my geek side, and I enjoy data science, and you need data in order to be able to make the algorithms work the way you want to. So whether it's Nikhil's device or Lance's system, ultimately there's going to be a chipset in there that's going to need to have some data to run on. The more data it has, the better. How do we solve that? Well, I think one is by passing law, right? So again, 21st Century Cures Act, right? Saying, hey, if a patient says, release my data, then everybody should have to release their data. It doesn't matter if you're a large dialysis organization. You say, well, I don't know, I've been dialyzing this patient for the last 7 years. I have tremendous amount of data, but I'm going to keep it all to myself. I think that's wrong, right? I mean, that's the patient's data. If they want to share that with someone else or another group, they should be able to do that. So I think fundamentally my answer is I'm glad to see our taxpayer dollars at work in terms of people looking out for the interest of our patients. In the meantime, it's negotiations and trying to build the relationships. So if you can't get it from Peter, then you go to Paul, and then you try and work there and try and find the ways to get the data that you need to make it happen.
Awesome. And guys, we're coming up on the hour. Actually, we're at the hour. I'm going to ask one more question. Any questions for the audience, please, for the panel, please let us know. By the way, your co-founder Vijay, he's on he said hi again. So anyway, so I was going to say, so like the last question we got, being creative entrepreneurial doctors, let's just say you had a successful exit. Okay. Exit guys out there means a successful exit means you need that acquisition, or you went public, or something happened, right? Someone acquired you. And let's just say, for all reasons, you have Mark Zuckerberg money right now, okay? Let's just say you have it. What would be your ideal next venture, or what problem would you want to solve? I know you're still trying to solve the problem you're in, okay? But is there something on the horizon in the back of your head, is like in medicine? What's the next venture or problem you would want to solve?
So I'll grab it, give the other guys a chance. So one, I would love to practice like a unblocked concierge medicine. So I'd love to practice with no limits into how much time I could spend on a patient and really spend a tremendous amount of effort with them. And then as a part of that, I'd like to be a part of taking care of people in the more remote aspects of the country. I know that sounds kind of...
That is very meaningful, by the way. I've actually started to do that with some telehealth, and it's really meaningful.
And that's just what I was going to say, would be to try and sort of re-engineer the front end of medicine if I can. Again, how can we scale that to people so that if you've got a screaming little kid in your arms and you're not sure whether to go to the emergency room or not, there should be some way that you can not drive an hour and a half to find your local emergency room. So I would focus on telemedicine, and then I would have just an incredible concierge medicine practice.
Nikhil, go for it, man.
Don't tell my
you're still like in the midst. I know you're still in the
It's hard to think about other things when I'm really in the thick of it right now. And cash is absolutely king. And we're facing that. But I will tell you this, that the team that I have and my co-founder Hip Win, just incredibly bright and brilliant. And we actually have a number of things in the background that we're sitting on while we achieve success, an ongoing success in Nephrodite. We certainly have things in the back closet that we're excited to pull out, not in a not too distant future. So we look forward to presenting those, but nothing that I can really talk about just right now.
Dude, you're a founder, and I know how busy you are. Lance, go for it. Any ideas for the future, sir?
I guess Dave and I are going to redesign the front end of healthcare. That's what
you can't steal someone's idea.
No, honestly, I've worked with a bunch of companies in different capacities, and I used to be sort of shiny object syndrome. They have something new, it's exciting, it's cool tech, and get excited. I mean, obviously, who can't get excited about AI possibilities right now? But the more and more, I've been around the space, the more I care about the people that I work with. So honestly, I don't have a particular area. If it's somebody that I enjoy working with, because in this business, it's like picking a bed partner. You're going to live with them, and you've got to be able to kind of just be yourself with it's not like it's going to be all professional all the time. So I'm looking for somebody to kind of hang out with and enjoy time with. And I think that's where I'll be most productive. That sounds like a dating.
That's what I was about to say.
That sounded weird. Can I cut that out? Can you edit that out of the program?
Let me tell you what I would love to do. I know this is about you guys, but I would love to practice. I'm getting sick of treating illness. I would love to actually help implement preventative care. Talking about exercise, diet, all those kind of things. Like, I think that's the real heart, and longevity, things like that. I think there's nothing like more like invigorating than to see like a 75-year-old that's productive and cognizant and like living life. Like, that's the amazing thing. And I know we're all trying to do that with our devices, but it's so nice to actually see that and in full health. But great, guys. So you know what? We didn't get as many questions as I thought. So, but we answered a lot. I mean, so I really appreciate you guys being here. Any final thoughts real quick?
Hey, Qasim, I know this is just such a great series that you're running, and I enjoy watching it every time. And it's really humbling. I know I'll speak for myself and for Leo to be a part of this. So thanks so much, and keep up the great work with this. You're delivering a message in a way that is fun and actually engaging, and hopefully bringing a lot more interest to this very, very needed area. Thank you.
Thanks.
Absolutely right. Thank you so much, Qasim, and for everyone that joined, that watched us. And it was such a collaborative and sort of laid back atmosphere, and even despite the Shark Tank pitch that you wanted us to do, but what an amazing.
Lance wants the $5, by the way.
Lance gets the $5. So
Lance, are you
much.
really at that point in your life where you really need the $5?
I texted Qasim a $5 Apple Pay request, and I didn't.
Yeah, I saw that. Like during a webinar, like a live webinar. That's what you do. Go for it. I thought. Go ahead, Lance. Last thought. Go for it.
I appreciate the opportunity, Qasim. Thanks so much. I think we need more things like this where we're discussing openly what we're going through and what people are trying to accomplish in this space, because I don't think it gets enough attention. There's a lot of focus on heart and orthopedics and the things that have high dollar, high value, but there needs to be a lot more focus on the kidney space. So thanks so much for having us.
Cool. But anyway, guys, hey, thank you guys for being on. Everyone out there, leave questions out there. These guys are all at stage in their companies where I'm pretty sure they wouldn't mind you reaching out on LinkedIn if you wanted to know more or get involved. Please. Or want to see their device firsthand, do a clinical trial, all that kind of stuff. These guys are probably really apt to do that. So anyway, you guys have a wonderful night, and always remember, it's your kidneys, your health. All right.
Thank you.
Take care.
Thanks, everyone.
Bye-bye.
Nice to meet you, Dave.
Very nice to meet you too, Lance.
Have a good night.
You too.